So we're going to start looking at that and talk about that. And so we'll talk about some common reasons why we might want to taper opioids. Talk about communication with patients. This is where having Evelyn is really helpful in too, and just this having the science behind psychology and how to communicate with people, I think is really helpful. And then just some of the basic steps on doing this, because again, when it's patient-centered, patient-driven, this goes a lot better. So here's basically those old, and I want to call them old at this time because we do have the updated 2022 guidelines, which give us a little bit more guidance on how to taper, but it's still well this. Um, Also, I can't speak to those of you in Delaware, but I wrote the state, or as one of the authors on this key concept. I think it's where some of these numbers come from. So as with the echo model, we'll begin with a case. So it's Mr. T, and he made an appearance in the Super Bowl ad from what I saw. It was nice to see him. But he looked a little bit older than 54. I hope that's okay for me to say, the real Mr. T. So he's a 54-year-old male with a history of chronic low back pain who's new to our practice. He is on oxycodone, acetaminophen, 10/325, 4 times a day, plus morphine suspended release, 30 milligrams TID for of morphine. He reports some significant constipation. He's got a history of obstructive sleep apnea. He uses a sleep apnea machine infrequently. He does not use any adjunctive treatments, and his PDMP is appropriate, and his UDS is positive for oxycodone and opioids only, negative for 6-monoacetylmorphine and fentanyl. He reports no other substance use. My approach is this isn't an easy process. Is to gain trust of the patient. And so on the first visit, I probably wouldn't make necessarily any major changes to his medications, but it would work on that this is coming in the future and how we begin preparing for it. And basically, I think it's probably a combination for work. He's got some obesity problems. He describes a very long history of having chronic back pain that has never really had good treatment for. And the doctor that he had been on just prescribed him opioids for years. And I think never really got to the bottom of what his etiology is. Hasn't had an MRI in years. Again, patient care, patient-centered, motivating the patient to want to taper, I think is really helpful. So I think we can consider opioid tapering when the patient wants to come down. They exhibit signs of substance use disorder. I think it's a whole little bit other topic when there's diversion of error behind much faster go about that. If we think it's just straight up substance use disorder, and we'll see in the slides upcoming, I think that's a good time to introduce the concept of buprenorphine or begin the transition period of that. If the patient starts showing an overdose or signs that he's showing up intoxicated, to me, those are reasons we would want to probably expedite this pretty quickly, and that may involve an inpatient stay as well. If the patient, another thing, if we're not seeing a functional improvement in our pain score by 30%, or we've kind of hit that plateau, that's probably another good time to start looking to start doing a taper and questioning the long-term use of his pain medications. I think part of it's also in a communications standpoint, it's a lot on how we approach the discussion with our patients. And we want to make sure that we're weighing the risks and benefit of the modality with the patient, as opposed to talking about the patient, if they're a good patient, if they're a bad patient, do they deserve medication? If we're having things of, should I trust the patient? Do we need to reward or punish the patient? That should be a warning sign that we're not making good clinical judgments for the patient. And patients and just the nonverbal, the communication language, um, is patients are very perceptive to that, and they pick up on these things very quickly. And so when we're communicating it's or we're thinking these thoughts, we're probably already communicated that to our patients, whether we intended to or not. As far as balancing risks and benefits, we also have multiple papers that are demonstrating a real harm in general. I like this paper in JAMA looking at a 10-year history in a cohort, looking at over 100,000 people. And the outcomes were was over an increased risk of overdose and mental health crisis. Both were statistically significant when we come down. Looking at case reports, there have been cases of physicians that when they have tapered medications have been shot and killed and pursued by aggressively in criminal ways by their patients. So again, I want to try to avoid those type of situations for us as healthcare providers, but also for our patients as well. So I think the goals of tapering is get the patient on board. A shout out to the people who are commenting, patient-centered approach is best. And I think maximize our non-opioid analgesics and a priority of their mental health first. So to Robert's point about, I think some of that also speaking to is what is their functional goals? What are they wanting to do? And in my practice, they tend to be a little bit older, but like the universally the most common thing is they want to be grandma or grandpa when the grandkids come over, and they're like, if I have 2 bad days and I struggle recovering, like I can do that, but I really enjoyed spending time with the grandparents. And so it's what do they need to do, and probably medicate a little bit of that day and maybe a day after, but just to know is, hey, we're going to be uncomfortable with some pain, and that's all right. The patient who struggles performing basic functions of daily living, that's another one that I think physical therapy may be really big help for. Also, we bring into the idea of chiropractic medicine, a number of studies for back pain, and a study like Mr. T, a, a challenge you guys to find something more robust, number of peer-reviewed, multi-center, randomized control trials showing better effectiveness than for pain than acupuncture for back pain for somebody like Mr. T, yet insurance typically doesn't cover it. It can be also an issue, but also things that I would look at recommending or considering for him. We want to prevent overdose. So I think one of this is as we go, we know this is going to be a stressful and this is a potentially dangerous the time for the patient, but knowing that we're not going to give up on the patient, that we're going to be supporting the patient through this, it's okay. Sometimes like I've done it before where it's like when we do the slow taper, I'm going to go 10% reduction over the course of a month. And on the first visit, if our patient was motivated, I might just say, hey, here's the normal prescription. Let's come back in a month. We'll get the MRI. We'll get some of these other tests. Let's see where we're at. But can you pick um, one every 10 doses or skip a dose twice a week in that? And let's see how you're doing with pain. And then when they come back and they still have a few pills in the pill bottle, you're like, hey, we made that goal, but the patient has the power. The patient is controlling that when they're having a good day, when they're having a bad day. Again, I think that's helpful. So that really feeds into here in this shared decision making, discussing our goals early, just avoid some of the confusion and stuff on the back end. Understanding that as we come down on their dose, that we may have some withdrawal symptoms, and what do those feel like, and that temporary increase in pain, maybe just a withdrawal thing, and could we try just a little bit of the pill just to kind of get us through it. And again, we have good days and we have bad days. with their mental health, with their physical health, and just speaking to the patient on adjusting pain on pain medication for a little bit less on a good day is oftentimes really helpful. What to taper first? I think, I want to borrow this top line from my last slide, and that's a patient-centered approach. Have a discussion with the patient. Um, if if you hold my feet to the fire, this is kind of the way that I would otherwise approach it, but whatever the patient, titrate down first. And so crisaprotol, or the trade name is Soma, I just don't think I've got a medical indication for why that drug is even on the market anymore. It's just dangerous and has addictive properties to it, very common in overdose. And I've got a lot better alternatives. So that's probably the drug that I would come off first. Long-acting opioids, again, the pain evidence over a month for a long-term benefit really starts dropping off precipitously. And if I can decrease my pain for those patients, again, that's what I want to do, and get them on the short-acting. Benzos can be really difficult, and in a future time we can talk about titrating benzos too. And then kind of the last is kind of that short-acting opioid. When the grandkids came over, we played all day, and now I'm hurting the unit. Is to have that short-acting is helpful. So this is a suggestion of approaches and different etiologies, and I so appreciate asking the question, what's the etiology first? And if they have a substance use disorder, I would suggest that we don't taper at all. We just begin the transition to buprenorphine. If you have access to methadone, I think equally as efficacious and something that we can do as well, just buprenorphine, or I'm sorry, methadone just doesn't have the availability in the outpatient that we have. If we think that there's a diversion, this is, we need a little bit more history here. But if they're truly they're not using any of the strips or any of the meds that were prescribed, there's no taper needed, and we can abruptly cut them off. The reality is that that number who's 100% diverting are the few and far between. It's usually that are giving some or lending some away. And that they still have it. And basically I honestly, my issue with diversion is I start taking it away and more of and taking away, I mean, a faster reduction here, but it also comes with closer follow-up visits, because again, the patients are at an increased risk and have challenges when coming off. If there's an immediate risk to themselves, and this is usually addiction related, or suicide type things, we need to move them to a higher level of care and maybe an inpatient bed. If it's a treatment failure, and we kind of talked about this, where as we increase an opioid, they're still not really getting any better. That's somebody that I would look to, again, decrease in a little bit faster, but again, as the patient can tolerate. And if they're at the same dose on for years, and some of these patients are just the way we inherit them, as the case continues, we discussed with Mr. T that the MMEs put him at a high risk for an overdose and a nighttime hypoxia. We talked about his treatment goals, and he shared with his medication. He reports that he continues to be in pain and not able to meet his own functional goals. And we discussed we're gradually exploring and beginning the taper. And I think I really appreciate all the wonderful comments in the chat, and seeing, comments about the spine simulator as well, with the patient, some of those. So again, this is just kind of, we're going to go slow, about 10% of the original dose over the course of a week or a month. And knowing that we may need to consult bring extra people in. A lot of this is developing the support system, having that trust with the patient and encouraging the patient that we're going to stick through them, through the good times and the bad times as they do this. Because again, when you're going into opioid or going into withdrawal or rapid taper, the last thing that we want is for the person to relapse as well. Would be again, dangerous situation for our patients. I'm just going to go through I've covered this material basically, and I want to make sure we have plenty of time for the case. So I'm just going through a little bit faster. So again, we started on a TENS unit, physical therapy, started duloxetine for some underlying depression. And Mr. T has ended up in the real case, responding actually very well to that. And again, just reinforcing we're not going to abandon our patients. We're not going to give up on them. We're just going to continue to be with them and support them. The other thing that comes up that I haven't on the slide is what happened when a patient's opioid, where they were just not able to decrease it. Give them another couple of weeks, give them another month, but kind of I tend to resist the urge of going up on the dose before coming down.